Hi, everyone. It's really nice to see you. Thanks for joining on time. I know your time is very valuable, so we obviously don't want to, for those that have joined, to wait too much longer. So we're going to continue with our teaching session for the supportive care program. Today, we're going to get into concepts that might be a bit new, but we're hoping will be really helpful because of the amount of work that you do directly with patients. We're going to introduce some interesting topics today about shared decision-making and how to help patients and families identify what their goals of care are. So generally, these types of conversations we have with patients who have chronic illness and have to oftentimes make decisions about their care. And sometimes it can be overwhelming for our patients. Yet it's also very important that we provide good quality information for our patients to make the best decision they can. So I'll introduce myself again. I'm Erin Das, a palliative care nurse originally from Canada. I've been with AHN for the last several months now, leading the supportive and palliative care program. And we're really happy that you're with us. We acknowledge that you've all taken time out of your day to join our supportive care program. And yeah, I'm eager to meet all of you in person. I've been able to spend a bit of time with some of our colleagues in Kenya, which has been really helpful. This past week, I got to meet Gladys, which was really nice. And I've recently met Fred. And I know Anson as well. I'm going to see them later on this week. So yeah, thank you for joining, and I hope you all will engage with the session today. So this is part of our regular kidney supportive care program and curriculum that we're going to be teaching at AHN. By the end of the session today, I'm hoping that you'll be able to understand the importance of shared decision-making, especially when it comes to our patients who have kidney failure. We're going to talk about how to identify goals of care with our patients and their families. We're going to review an example of a clinical guideline on shared decision-making, and then I'm going to introduce to you a tool. I shared it on the WhatsApp group earlier today, but the tool is called the Serious Illness Conversation Guide. Sometimes we need to use tools when we talk about supportive care just to help guide our conversations, and printing out tools like this and having it in your kind of notebook that you take around with you as you plan family meetings, or if you need to engage in a difficult conversation with a family or a patient, having it printed out is actually really helpful for you to memorize. How to have these kinds of more serious conversations isn't necessarily important. It is important that you find good ways to cover all the kind of important areas in these conversations. So I think finding good ways to use tools is really effective too. So we're hoping that you'll also begin to be able to facilitate shared decision-making with your patients and families as we go throughout this course in the session for today. Okay, what is shared decision-making? So in 2021, 2013, and 2020, a variety of people came together. So I've been able to take content from a variety of presentations and guidelines and recommendations, and everyone working with patients who have kidney failure and also thinking about supportive care or palliative care, holistic care, have all come together and decided that talking about shared decision-making is really important. So a basic definition is that we would define evolving goals of care, values, and priorities of our patients and their families. Shared decision-making also helps us while we navigate complex family meetings. So one aspect of supportive care is helping initiate family meetings. And that would be when you invite a clinician, maybe administrative staff, the nurse, potentially the nephrologist or the main physician that's taking care of the patient, the family, and the patient, all kind of coming together to have a discussion about their care. And shared decision-making is kind of at the base of these family meetings. So worldwide, people tend to make choices about their care, and they do this in collaboration with others. So it could be with their broader family, it could be with their religious affiliations, or people within their religious communities, as well as within their cultural groups. Many important life choices, therefore, don't necessarily only impact an individual or a patient, but actually these choices impact families and communities. And we know this, especially for our kidney failure patients related to dialysis sessions. It doesn't just impact our patients. It impacts the family, it impacts the community, sometimes a caregiver who has to come and support a patient. Making these decisions, it isn't just about the patient. Yet we know at AHN and many other facilities that are providing dialysis care, we want to make sure that we provide person-centered or patient-centered care. And this also comes into play when we talk about shared decision-making. So there is an increased recognition that autonomy, or a bit of independence related to what a patient wants, related to their care, is really important. We know that this can come out differently based on cultural values and what that looks like. But we know at AHN, patient-centered care is quite important to the care that we give. So here's an interesting image I wanted to share with you. This is from 2016 and an article that was published in the Clinical Journal of the American Society of Nephrology. And in this discussion, this is where it kind of describes the different clinical and patient interactions that can occur. So on the left side, you can see that the clinician, so this could be the nurse, this could be the clinical officer, even the nephrologist, can have their own beliefs and values, their own spirituality, their own ethnicity, they're working within a healthcare system, and then their own experiences. It's really important that we as providers are conscious of our own beliefs and values, because they will interact with how we interact with our patients. So on the right-hand side, you can see there is the patient. The patient, and I would probably also include the family, has beliefs and values. They have their own spirituality, their own ethnicity, their own concept and understanding of health, and their own experience. And it is really important that as we engage with patients and families, we know that there may be some commonalities, so some things that are common in our interactions related to these concepts, and then there may be some things that are not common. But we need to acknowledge and understand that, because it will impact how we care for our patients. In the same article, they went on to describe what it means for us to become culturally competent in how we communicate and engage with our patients. So a communication task or strategy would be to understand the patient's experience. So we want to build rapport and have that therapeutic relationship with our patient. We want to be curious about and related to our patient's experience, and also understand how they interpret their condition. So what do they understand about their illness? We also want to give information. So we assess how much they know about their current situation, and then we ask what kind of information they want to know. Some people would want to know a lot of information, and then some people don't. And I think when we talk about shared decision-making, we need to understand what our patients want as well. We then give information concisely without information and words that are very medical, so that we can ensure that our patients understand. We do need to also, through this process, determine what is the patient's involvement in decision-making. So historically in the past, have they been part of their own decision-making, or is there someone in their family that helps make their decisions alongside them? Or do they actually have a full substitute decision maker? Are they not able to make their own decisions? So therefore we'd have to engage with someone else to make their decisions on their behalf. Through this process also, we want to understand their values and their beliefs. So that's asking about what's important to them and what concerns them the most. We need to be transparent by addressing trust in our relationship with the patient, and then identifying and addressing any needs that they may have. And all of these, again, we're not going to be able to memorize all of this. This is a lot of information and maybe quite a different way of engaging with our patients than we have previously. So using these kinds of tools can be really helpful. And again, we will get better with practice and with time as we talk to our patients and communicate in this way. So this is a theory or a way of providing care to our patients. So here in this image, we have our patient on the left. So they're trying to make informed decisions. So patients make informed decisions based on a variety of things. They make their decisions about their health based on their experiences, their skills, their knowledge, motivation, their views, and also their culture. They also, for sure, make decisions based on what other people and other information they have access to. So it could be through their media, could be through their friends, family, other patients, the certain social infrastructures that they currently have access to, and others. We as healthcare providers try to support our patients by making decisions and giving healthcare, so delivering healthcare, and often that's done through evidence, so evidence-based decisions. So again, we also look to our experience, our skills, our knowledge, our motivation, our views, and our culture. And then as we look outside of our individual self, we look to medical evidence, our clinical team, again, that health infrastructure and the policies. What we're trying to advise as we think about shared decision-making is in the middle there. So if you can see the letter C, what we want is actually where we both come together, where this is a discussion and a consultation that happens when we engage with our patients and have shared decision-making that's based on evidence. And it's based on an exchange of understanding, a reason about preferences that our patients have, and then we implement agreed choices. So we as the provider bring our evidence-based decisions and information. Our patients are coming with information as well based on their own values and other experiences they have had in the past. And together we make that shared decision. It's not the provider saying this is what you must do and the patient saying, okay, I trust you, I'll listen to what you say. It's much more involved than that. And this is something that we all are striving to do as we engage with our patients who have kidney failure. So it's really important that physicians, even clinical officers or nurses on the call with us today, we all have the responsibility to provide competent patients or their decision makers with enough information about their options. So for a patient who has kidney failure, this means we need to find good ways to explain all of their options. So we need to explain the benefits, the burdens, and the consequence, the different modalities of dialysis, and then what alternative options are there? Are there options for kidney transplant or potentially conservative care? Again, we need to discuss the benefits and burdens with evidence-based as much as possible. So we need to make sure the data and the context that we're sharing is based on evidence. And this, again, is really important as we share information with our patients. When we think of the term goals of care, it's often referred to the entire process of making medical decisions. But it really has several components, and that, again, is identifying the values, goals, and the treatment preference of our patients. It can involve making decisions for the future, and if it's related to decisions for the future, we often call that advanced care planning, or it can be related to making decisions at the present time. So if we're talking about something that may happen in the future that's not currently happening, we call it advanced care planning. And then if it's about the current situation, we call that goals of care or shared decision-making in the present. These kinds of conversations can happen in our hospital settings, as well as they can also happen in outpatient or our types of clinics. It is really important that our patients are educated so that they are able to make those really important decisions alongside information that we're giving them too. So patients are able to make these decisions when they are empowered, when they feel understood, when they're informed, they have access to the right information, then they are able to make good decisions. And all of this is related to a concept called health literacy. And we know in many of the places where we're working, sometimes health literacy is not always very high, but it is part of our job to improve our patients' health literacy as we provide care. And that is a big aspect of the supportive care program that we are focusing on at AHN. So I want to introduce to you a concept. It's called REMAP. So REMAP. And this is a way for us to guide conversations with our patients related to their goals of care. So it's an acronym. So it stands for reframe, emotion, map, align, and then propose a plan. And this was developed by the American Society of Clinical Oncology in 2017. It was often used for cancer patients, but I think it is an interesting tool as well to be able to use for our kidney failure patients. And here's another way of looking at it. So the first one is reframe. So sometimes we need to have discussions with our patients about their goals of care when the current situation isn't working so well. So we may say, given the current situation or given the recent change in your status, it seems like it would be a good time to talk about what to do. We potentially are in a different place than we were 6 months ago or a year ago. We need to expect as providers that our patients will have some sort of emotional response to the fact that we think that their current situation is a little bit different than it had been maybe 6 months or a year ago. And we can respond by using empathy and saying things such as, it can be really hard to deal with this all right now, or I can see you're really concerned about the change in how you're feeling, or the fact that you can't do the things you wanted to do previously. Is it okay for us to talk about what this means? Is another, again, interesting way to engage with them, showing empathy. It's important that we then map out what's important. Given the situation, so given the change in your current situation, or maybe the patient isn't able to work anymore, or they've had more symptoms than they've had in the past, it's important for us all to ask, what's important for you? When you think about the future, are there certain things that you want to do? Again, as you look towards the future, what concerns you? And this all helps us understand what's important to the patient. We then align with the patient's values. So again, we need to ensure that through the supportive care program, we find good ways to align with what's important to our patients. So one thing we can say is, as I listen to you, it sounds like the most important things are that you have less pain. Or it sounds like the most important things are that you spend really good quality time with your family, or that you spend time in your garden doing the things that you enjoy doing. We then need to make sure that we plan to match their values. So here's what I can do that will help you do those important things. What do you think about that? And here we can make a plan and make some recommendations of how to follow up with what is important in the values that our patients have. So if they're in pain, we come up with a pain management plan and then make sure that they're in line with that. And these are all ways to address our patients' goals of care, their overall kidney supportive care plan. Some other ways that we can map or understand a patient's values, we can say, what's most important to you now with what you know about your illness? We could also ask, as you think about the future, what concerns you or what worries you? We can also begin to understand their life outside of their clinic or their hospital. So we can ask questions like, what kind of things do you think you like to do when you're feeling stronger? So it could be on the days in between dialysis treatments. It could be the evening before their treatment or the night right after their treatment. These kinds of things can, again, help us understand our patients and what's important to them. What are their values? So in 2010, the Renal Physicians Association in the US published recommendations of how we go about shared decision-making in the appropriate initiation of and withdrawing from dialysis. So when we start dialysis and some of our patients who stop dialysis, these kinds of decisions are actually really key, and they're quite overwhelming at times, not only for the providers, but also for the patients and their families. So this was an interesting clinical guideline that was released. It is several years old now. It's 14 years old. But I thought we could together review some of the recommendations, and I think it can also help us understand how we at AHN go about the shared decision-making model with our patients. So the first recommendation is to make sure that we have a physician-patient relationship, and I think this goes back to our patient-centered care, especially for the shared decision-making. So we need to make sure that shared decision-making is the preferred model for any sort of decision-making that occurs. It can't be the physician is the only one making a decision, and it needs to ensure that our patients are informed about the risks and the benefits of their treatment, and they play a really important role in making these decisions. Based on the number and the complexity of the decisions involved for treating kidney failure, it's important that we do this in our patients, especially our patients with acute kidney injury, stage 4 and 5, with chronic kidney disease, and especially those in kidney failure or requiring dialysis at end stage. At a minimum, these decisions need to be made between the patient and the physician. It cannot only be the physician making the decision. And if the patient isn't able to make a decision, then finding who is the substitute decision maker, or who would make a decision on their behalf, the patient's behalf, if they're not able to. Recommendation number 3 says that it is important for us as providers to estimate the prognosis of their overall condition. So depending on the setting, a primary care physician, a nephrologist, or someone who else is familiar with the patient, it's important that we communicate a patient's prognosis. And this can also help them make decisions going forward. Recommendation number 7 says that potentially we could offer a time-limited trial of dialysis for patients who require dialysis. And what this looks like is this is a time-limited trial of the treatment. And this would be conducted by the nephrologist or the treating physician, the patient, and the patient's family, all agreeing in advance on the length of time that a trial would be and what parameters would be included when the trial is finished to decide whether the dialysis had benefited the patient or not, and therefore also should the dialysis continue or not. This is a kind of an interesting way to think about dialysis and the treatment plan, making sure that we're having shared decisions with our patients also. Recommendation number 10 says that we need to use a systematic approach to communicate with our patients related to their diagnosis, their prognosis, their treatment options, and then again, their goals of care. So good communication really improves their adjustment to their illness and increases their adherence to treatment, resulting, of course, in higher patient and family satisfaction with their care. Patients appreciate the sensitive delivery of information about their prognosis and the ability to balance reality while maintaining hope in their situation. It's important that we communicate in a way, again, with language that's easy to understand and that our patients will be able to comprehend. Patient decisions should be based on their understanding of their condition and the pros and cons of their treatment options. And again, we need to facilitate that effective communication. Oftentimes that includes multidisciplinary approach. So including the others in the team as we have these kinds of conversations, ensuring that our patients are informed. The last tool that I'll introduce today is a tool called the Serious Illness Conversation Guide, We then are going to have a chance to have a short discussion about a case that the team in Rwanda wanted to share. So this is an interesting guide that we use that helps us create our conversation with our patients. And it was developed back in 2015 in the US in a hospital called the Brigham and Women's Hospital, as well as the Harvard T.H. Chan School of Public Health, in combination with the Dana-Farber Cancer Institute. And in this tool, they have used patient-tested language to identify how to set up a conversation with a patient. So that's what we're going to look at initially. So the way that you can address a patient, so you've already arranged a time with the patient and a family to talk about something serious in their illness. So in this situation, we set up the conversation by saying, I'd like to talk together about what's happening with your health and what matters to you. Would this be okay? So again, you could say exactly these words. These words have been used on a variety of patients and have been validated and often have led to really positive conversations with patients and families. The next thing we do is we need to assess. So we could say next, to make sure, as long as the patient has said it's okay to talk about what's going on with their health, we then could move on and say, to make sure I share information that's helpful to you today, can you tell me your understanding of what's happening with your health right now? So this helps us understand what the patient knows, what does the family know, and this also will affect what we say as we go forward with the rest of the conversation. If they already understand aspects that we thought they may not understand, then it would change the way we go forward. So we get an understanding of what they know. We then would ask how much information about what might be ahead with your health might be helpful to discuss today. Again, this also helps us understand what information they're interested in and what would be helpful for the discussion. As we move on to the next step is about sharing. So can I share my understanding of what may be ahead for your health? So we as the provider also need to ensure that, so we want to share a little bit more information about what we understand about their current situation. So we might be uncertain. We might be uncertain about exactly what's happening. And therefore, we would want to share a little bit about that uncertainty. We may want to share some information about the amount of time that a patient we anticipate related to their prognosis, for them to be living. So sometimes we would engage in these types of conversations when a patient is closer to the end of their life. We also may want to share some information about a patient's function. So potentially they're losing their function. It can be a difficult conversation. So we also then would potentially want to talk about that in the discussion. So say we wanted to talk about their function, we would say, it can be difficult to predict what will happen. I hope you will feel as well as possible for a long time and we'll work towards that goal. It's also possible that it may get harder to do things because of your illness. I think it's important that we prepare for that. And then, of course, it's very important to pause and allow for silence of validating and exploring any emotions our patients may have at that point. We then want to explore. So we want to explore the important goals, any worries or strengths that our patients have. We can ask them if there's specific activities that bring them joy or meaning in their life. And we continue with the questions that are mentioned here. At the end of the conversation, we want to close and we want to summarize. So we then say, I'm hearing you say, and then we fill in the blank, is really important to you and that you're hoping for. So any hope or wish that a patient has in the current situation they're in. Keeping all these things in mind, we could then say, we know, and what we know about your current illness or your kidney failure, I recommend that and again, we fill in the blank. This will help us make sure that your care reflects what's important to you. How does this plan seem to you? And then at the very end, we as the provider would say, I will do everything I can to support you through this and make sure you get the best care possible. And I think this is a very truthful statement about what we can provide and the support that we can provide at AHN. So this, again, is just a tool, another tool that you can use as you think about engaging in these types of conversations with your patients at AHN. And I do want to reiterate that this does get easier with time. So as we have more of these types of conversations with our patients, we're able to do this better and more effectively. So I'll take a few minutes for questions. I know that we also have our case discussion, but does anyone have any particular questions about shared decision making that they wanted to ask for today? I know it may be a new topic to go into so much detail, but if you have any questions, I'm available.
It appears there are no questions. I think you can proceed, Erin.
Does anyone feel that they are able to make these kinds of conversations, or you haven't had the opportunity yet? Sometimes it can be hard because we aren't always the primary physician at AHN. Of course, we do have Dr. Yuri that obviously supports us in terms of clinical medical management. Sometimes it can feel like it's not exactly our role because we're not the specialist. But I think as you learn more about supportive care, aspects of shared decision-making will be really important. Well, maybe if you have any other questions, you can share them in the chat. I'll share my screen for Jean now. Azail, he's prepared a case study of a patient, and I thought we could go through it for the last 15-20 minutes.
Okay, that's great.
Let me know if you can see my screen. Okay, karibu, or welcome.
Yeah, Santa, thank you so much again, team. So I won't take much time about this case. So it is one of the cases we have seen from our units. So since this program of kidney supportive care came in, so we had been facing some mental issues among our patients. This is one of the cases we normally had. So I will take a short time to go through it so that we can have a time of discussion as well. So starting from patient details, she's 49 years old, and she was diagnosed with CKD stage 5 since 2021, but she has the history of hypertension since 2002, which is currently controlled with the medication she's currently taking. So she's one of the patients we are treating from KIMI. KIMI is one of our centers. Is located in Kigali. So this patient is attending dialysis at KIMI. So that's a brief details regarding patient diagnosis. So about her demographics or background, she's a teacher holding a bachelor's degree in language with education. So she divorced with no child by now. So she had some issues with her husband since she was married to someone. Since she got CKD, her husband abandoned her and later on decided to divorce, but she kept coming for dialysis with all of those social issues or social problems. So unfortunately, she lost her family members in a tragedy, in a genocide happened in Rwanda, 1994. And currently she's living with her sister since she divorced with her husband. Since she divorced with her husband. So briefly, she's an intellectual person. So that is why maybe she later on developed some of the mental issues. She has been struggling with different issues, either from social, family interactions, family issues, social status from the family members. She has been in a midst of many problems that was sometimes hindering the clinical status of the patient as well. So as medical history, she's a CKD patient, and she's doing maintenance dialysis 3 times a week, as prescribed 4 hours each session. She's compliant and other treatment as well. So the background of this case, she had a past diagnosis of mental disorders. The doctors diagnosed her with depression that was successfully managed in the past, and currently she's presenting some of the signs or recurrent episodes of depressions as we interact with her on a daily basis when she comes on dialysis. So this is one of the issues she's facing since day one, but her clinical condition or her mental status is going down. Maybe it is still deteriorating according to how she's presenting nowadays. So as medication, she is taking Resix, junior aspirin, vitamin B complex, vitamin C, Caroshare, Meditrol. As you know, most of the patients are having issues. Most of the patients having the issue of CKD, they are most found on these medications, plus antihypertensive medications as well. So as a lab results, she has good hemoglobin. There is no current sign of infections. Red blood cell is okay. Platelets is okay. So sodium and the other clinical parameters are within normal range. So basing on holistic assessment, either pain and symptoms, including relevant treatments. So clinical examination shows that her vital signs are within normal range, as you can see, and she's alert, oriented, and comfortable at some point on dialysis. Her weight has a downward trend. BMI has been changing due to most of those issues, because she used to have the history of lack of appetite. So she has been having her BMI dropping since a couple of weeks ago. So ranks and heart, there was no abnormalities, no abdominal tenderness, no distension or any mass from either abdominal or somewhere else. So the only current clinical issues she's presenting is, and which is terrible, is somehow her mental status or her mental status. As of now, it is one of the critical cases we are having in the unit, because she has been presenting most of the symptoms related with depressions, anxiety, being refusing clinical staffs. So it is a major challenge we are facing from the unit. So basing on holistic assessment tool, as you have seen, she has no pain, no tiredness, no drowsiness, no nausea, but she used to have a lack of appetite since she has been attending dialysis. So we found that she was frequently complaining lack of appetite at home, and even when we provide snacks on dialysis, you can even witness that while she's taking snacks or maybe a meal during treatment. So moving again, regarding, as I have mentioned, she has been experiencing some of the episodes of depressions and anxiety as well, which is sometimes affecting her overall life or overall clinical status, so which is affecting the well-being of the patient, since she's refusing most of the clinical staff, most of the family members. The interaction with the other people is quite not enough, and it is a serious issue because sometimes in the unit she can only agree one nurse to connect or disconnect her on dialysis. Whenever that nurse is not there in the unit, she refuses all of the remaining staff maybe to do or to give care to the patient. So it is one of the critical cases we are having since we have diagnosed that, since we had the history of having depressions in the past medical history. So we have been treating her according to her clinical status. We plan even to involve a psychologist, but as that department was not feasible, we recommended her to see a psychologist, but she couldn't accept or do or move with a proposal, which is that's why it is very important for us to implement these programs so that we can help most of those patients we are having from our units. So she doesn't have any issue with itching, sleeping problems, restless leg, or any other clinical manifestations. So according to APCA POS toolkit, so when you are discussing with the patient, as we have seen that those are some of the questions we can ask to the patient to know how she has been doing, maybe in the past 3 days. Most of the time you will find these patients are complaining, and sometimes she refuses to talk to the staff members, to the other patients. She will be in a depressive mood, which is quite challenging for us as a staff and also the family members as well. So this is the score, as you can see. So she used to feel sad, have something like anxiety, being introvert, unable to interact with the other personnel, and she's very distant in case you want to give or provide some advices, support, or discussions. So regarding the family members, we have been she has been coming with some of the family members. So but since then the family started giving up on her, and she is currently alone, which is sometimes making it hard to even find some family members to discuss about her conditions, her case, so that they can support accordingly. So since the time she was still coming with the family members, we tried to take some time to discuss with the family members, explain them how they can support her, how they can be supportive in this case. So unfortunately, as the days kept going, the family became very distant to her, which is making her situation even worse, as we can rule out that clinically as of now. So psychological concerns, psychosocial concerns regarding this patient. So the interaction with other patient is somehow very limited, and she's withdrawn, abusive, and aggressive. In case the other patients wants to talk to her, she's actually not cooperative. With the interaction with staff members, some of the time, sometimes she became aggressive towards nurse assistant and also sometimes nurses, as I have touched upon above. So sometimes she accepts some nurses, the other time she refuses all of them, only accepting one nurse. And in case that nurse is not available in the unit, it will be very complicated to connect this patient on dialysis. So I may say the interaction with patient and the other staff is not sufficient, if I may say, which is sometimes making her treatment complicated, as we can tell from the current status she's experiencing or presenting the unit. Okay, next, please. So when she's communicating with the other staff, she speaks fluently, no slurring on herself. Whenever she wants to speak, she can speak openly. She does not express positive emotion verbally or non-verbally. Mostly her facial expression shows she's having anger most of the time. And she used to look like withdrawn, avoidant at this time, trying to approach her causes a physical and a verbal aggressiveness. So whenever I want, maybe you want to approach her to maybe to say hello, if you want to check on her, sometimes she responds in a very aggressive way. So that is why in some cases, whenever she's connected, there's nobody who is going there to see how she's doing. Maybe nurses will keep on monitoring the signs and symptoms of these patients, either if the patient is having hypertension or other intradiabetic complications. So her communication is not effective because most of the time she's avoidant to all of the people, staff and patients, which can even make it hard to communicate with her to know how she's doing, how she's maybe interacting with the family members, or if there is someone who can be supportive or help in any way. She's spiritually, as we have seen from the recent presentations, she's a Christian, she's a Catholic believer, and she said that she is attending Holy Mass on Sundays. And we have been trying to see if we can involve church people from the church, if they can be supportive, because she's not living far from the church. We believe that most of some of the people from church may be close to her so that they can help us maybe in providing social support or psychosocial support to this patient. Next, please. So, according to current collaborations and partnership in care, nursing team has incorporated the nephrologist about the case. For now, with no signs of improvement. So this case was reported to the nephrologist, and he tried to make sure that he discusses with this patient, and unfortunately, this patient was not collaborative. So we encouraged one of the family members to improve taking care of her. Now, after each dialysis sessions, there is a family member who come to pick her. As from the request we made from the family, so one of the family members committed to come at each session to pick her at home, but sometimes they miss, and she's even refusing them to come, which is actually a challenge we are facing on both sides, because sometimes family want to support and she refuses. But for us as a team, we managed to encourage some of those family members. We called them via phone. So one committed to come and accompany her on dialysis treatment. So we are also planning to incorporate a psychologist in the managing team for this case. We had conversations with the local psychologists to see how they can be supportive to some of these critical cases, because the gap we have identified from these cases and the other cases is that whenever we refer them to the other hospitals where they can find maybe a mental departments, so they never go there. They just stay at home and they come on dialysis. So, which we found that cannot solve the issue, and even the nephrologist may support, but not in a full position to provide a psychosocial support to these patients. So that is why we are planning to incorporate maybe psychologists so that they can participate in management of this case. So as a summary of this case, she's a 49 years old female patient with CKD, stage 5, with history of hypertension, which is currently controlled, and she was diagnosed with depression in the past and currently taking medications. So as I have mentioned, she's a teacher. in a secondary school, living with her sister since she divorced. And she's always aggressive to both staff and the other patient, and most of the time not interested in discussions with other patients and the staff as well. So now it is becoming to get nurse to care for her on dialysis. So we managed to find someone who can be like one nurse who is dedicated to take care of this patient. So they have been collaborating to each other in a very conducive way. So we are maybe seeing if we can introduce the other staff, because we cannot be sure that that nurse will always be in the unit. So it is still a challenge. That is why we are planning to work with multidisciplinary team to make sure that we can facilitate. So this is the questions I reserve for the audience, so that we can work together to find a way we can support or help these patients collaboratively. The first question is how clinical staff should manage these patients accurately. That is the first question. The second question, what should be the approach clinical team could use to explain to other patients who ask about this case, ensuring confidentiality and veracity principles? Lastly, how other patients should communicate with this patient effectively? So allow me to say thank you to all of you. And if you can be, if you can just take a few minutes to discuss on this case, it will be very helpful for us as a team, so that you can manage this patient accurately.
Thank you, Jean, for really working really hard the last few weeks to bring the case together. I think you did a really good job, and I think it just continues to highlight how supportive care is really holistic, right? We talked a lot about the variety of symptoms that our patients can deal with, and you've brought in a really interesting case where the patient's psychological situation is really impacting all aspects of her care and really affecting a lot of the staff even at the clinic. So I see a few other people on the call: Fred, Francis, Anson, Lillian. Anyone have any initial thoughts for the team in Rwanda? Azael, of course, you can also share if you have any thoughts, but does anyone part of the group have initial thoughts? I will also share after, but I'd love for some of our participants to share as well.
Maybe if I can go ahead. Jean, that's a very great case, and I see it's very challenging. But I think, as you said, maybe this case need multidisciplinary care, at least to involve us, the psychologist, at least to have different people to see how we can come with it together. But I'm not sure with the family support. You can also try looking if we can try talking to the family member, maybe to involve them. I know if he's not trusting the staff, maybe there might be one of the family member that she is trusting, and then we can see if we can have a room to involve them, if not yet. But it's a kind of challenging case. Congratulations for the effort that you made so far.
Yeah, I would say especially if the patient has a known history of depression. We know that depression is also a serious illness. So I would say, just looking, Jean, I just put in the list of the patient's medications. I think we know that patients who have depression, clinical depression, can really benefit from being on medication to manage their mood, to manage their emotions and their outbursts. So I would say, as our clinical staff, we should get an assessment of her medications. If she's not willing to take medications related to her depression, we need to identify why. Are the side effects too difficult? Is the medication too expensive? Is there too much stigma around that? I would say this patient, based on the story that you've shared, probably needs to go back on medication for at least, I don't know, 4 to 6 months. Medications for depression and mental illness can take time to start working effectively. So usually they take between 2 to 3 weeks to start working. And then, I mean, it's not going to necessarily be a medication she can get off quickly. So, yeah, I think working alongside the psychologist, and potentially if the medications are not appropriate for our team to prescribe, then getting a psychiatrist to look at it, because it does seem like it's affecting her physically, and is becoming very difficult for our staff to support her. Probably she needs that as an initial step. I'm not sure if Rwanda is very similar to Kenya, but accessing counseling therapy is often difficult for our patients. But if there is an NGO or a faith-based facility that does counseling services at lower costs, I would suggest that's probably at the same time as her medication, starting them both. Potentially there's some trauma that she's experiencing that we're just not fully understanding at our clinic, maybe because we're not fully trained in that. But if it's possible, if they would be willing to visit her when she's getting her dialysis, maybe that would also potentially help. I mean, maybe it's easier if it's at her home. She's pretty young. She's only 49. So I think coming up with a holistic plan for her would be helpful. Yeah, it's in terms of confidentiality with patients, I think our other patients would see her in distress, and I'm sure they're concerned about her. We need to make sure that we don't talk about her case to other patients, yet also find ways for our patients to, you know, also show empathy to her. Maybe there is one other patient that she seems to get along with, finding ways for them to potentially sit near each other, if that's the case. Yeah, it can be difficult because we don't want to give too much information to other patients, yet I'm sure they can see that she's very distressed if she's trying to hit people and is shouting or is talking like that. I assume not all of our patients would have dealt with someone with severe mental health issues like she's struggling with. Yet our patients, I do believe, understand that coming to dialysis is it's very difficult for some of our patients. So I do think that our patients can show empathy to others. They may not know exactly how to deal with someone who has a serious mental health issue, but I do think that they probably would be able to show kindness to her, knowing that they're also dialysis patients and they've gone through very similar issues. Lillian, do you have any thoughts? Or Francis, I know we've gone over time, but anybody else want to comment? Okay, well, thank you, Jean, for taking the time. I know that you were working hard the last few weeks to put this together, and thanks for being our first case for the Kidney Supportive Care Program. I think it was a really good case. I'm going to share this with the other clinical team, Dr. Lloyd, Dr. Mazar, and Dr. Yuri, to see if they also have any recommendations. So thanks so much.